So, Namaskar everyone, and welcome back to my channel again and to this series, this continuation of this series where we are talking about Boger's concept and trying to understand how Boger thought, what was his philosophy. And now we are in a section where we are talking about, we are going to learn from clinical cases, which I have found here and there. I'm just trying to retrospectively learn from it and see how and what approach Boger took and what best we can learn from these clinical cases so that we can use it in our practice. So let me directly go to the case itself. This is a very interesting case. And now this series is of clinical cases. And this again is case of Boger. So let us analyze this case. So of course, I have taken this case from a very nice book, especially you should have it on your desk. Essential of Boger's Principle and Practice of Homeopathy by Dr. Shashikant Tiwari. There's a chapter on clinical cases. I got this case from there. So let us first go through the case and then we'll understand it. April 4, 1931, J.W., a thick-necked bookkeeper, age 79, on the way home, had been taken from the streetcar because of his violent vertigo. So this guy, 79 years of age, there's a constitution that he describes. Remember this, thick-necked, very important here. I'm just giving you some hints, okay? Had gone, so he was on a streetcar and he had a severe vertigo, so he was taken home. What are the modalities of the vertigo then? Vertigo, bending head backwards. Whenever he is bending his head backwards, he's getting vertigo, staggering gait, and there is a lot of weakness in the legs. Right hand tremble. There is trembling of the right hand. Left pulse. Left hand pulse was intermittent. Redness of left sclerotic with puffs under eye. There is redness of the eyes, left side. Some diplopia was there, and what on right upper eyelid. These were objective symptoms. Nightly urination, bad taste in AM, bluish, suffused, expressionless face. That's the case. Now we have to guess the remedy. So best thing would be, you can pause this video right now, read the case, you have the case in front of you, go and work out in your repertory and see where it can lead to you. Actually, the remedy that was given was Tuja in this case. Tuja DM. One dose, reaction occurred in 24 hours, and on May 2, he was back to work again. December 29, no feeling quite well, left eye red pain again. Again, Tuja, one dose was repeated. He returned to work the next day and had so continued until now. This was very evidently a case of impending apoplexy. That's what the author writes. So he understood. He got vertigo, but it was a case of impending apoplexy. Maybe clinically understood that a little bit more delay, he would have gone into apoplexy. Now, so we know the case, we know the remedy. But when you just look at this, when you just look at the case, we should know why Tuja was given. I started thinking myself, asking myself, why was Tuja given? But this answer is not given there. The problem with these clinical cases and the old literature cases is that case remedy. Analysis is missing. If analysis is missing, then it gets really difficult and boring to understand. And when a homeopath doesn't understand things, he gets away from these books. So it is my humble appeal to all the clinicians to try to decode the cases to their best of the best abilities. That will be very helpful for the students and homeopath doctors who want to really learn. Because just seeing the case and remedy, you can think vaguely any remedy, right? So let us decode this case. Basically, let us decode. Now we know the remedy, right? So what I did is that before looking at, of course, I knew the remedy, but I said, let me look at the case a new and use all the approaches, the Bonning-Ossen's or Boger's approach, and repetize. So what are the symptoms? Important symptoms. Vertigo, bending, aggravation, bending head backwards looks important symptom, right? Of course. Vertigo, when patient comes with vertigo, we generally ask them the modalities. Sitting, lying in bed, turning in bed, looking upwards, downwards, stooping, eating, drinking. Those are the modalities. So here we get exactly whenever patient is bending in his head backwards, it gets aggravated. The first symptom is this. So this is very, and this is a particular symptom, okay, not a general symptom, but a particular symptom. Problem is in Boger, we don't find the symptom. So if you open Boger synoptic key repertory, exactly you go in a particular chapter, you don't find this rubric itself. BBCR we can go through and locate. Definitely you can go in bigger repertory like BBCR, Boger, Bonning-Ossen repertory. In synoptic key you will not get, but BBCR you can definitely locate the symptom. The symptom would be rather Bonning-Ossen, vertigo, aggravation, bending backwards. But there are only two remedies, clonine and Seneca. Now, here is a very big catch. We feel this is a very important symptom. We look into the repertory and how many times it happens like that, that we come across a rubric where 1 or 2 or 3 remedies are given. Sometimes we can get really excited about it. Wow, there are only 2 remedies or 1 remedy. But the biggest mistake also happens in these rubrics alone. Now, these are very risky rubrics. Why it is risky? Because definitely that is one symptom. We are not denying it. But look at the remedies, clonine and Seneca. So clonine and Seneca, the remedy in the rubric has to match to the patient. Listen to me carefully what I'm saying. The remedy into the rubric has to match to the patient. If it does not match, you have to discard the rubric. You have to discard the rubric. So when you read clonine and when you read Seneca, go and read from Boric, the generalities, the vertigo, modalities. What the case that we have in front of us, it has no matching. If you look at clonine, all the congestions and headaches and bursting, blood pressure, it's not there. Same with Seneca, respiratory and other aspects of it. It does not match. What do we see here is prominently left side. There's another side, when we come to the region part, like 5 steps, if you remember the region part, he says take organs, but also take sides. So when we look at here, something to do with left sidedness is there. What on upper eyelid? Another symptom is what on upper eyelid. Nightly urination. Other symptoms. I'm just trying to put down the symptoms. Now, what we can do is that we can form totality with these remedies, but I tried doing it. What happens is that you can also try doing it. You can put side left, night urination, what on upper left, and vertigo bending backwards. All take it and make a totality, but haphazard totality will emerge. Not guiding towards one single indicated remedy. So, we talk about this rubric again. Vertigo bending backwards. If we just take this one particular symptom and analyze, then of the both drugs has to match, which is not in this case. I explained you the reason. Even Kent, this is very interesting. You should read Kent's lesser writing. And you'll get an understanding, especially on the chapter of repertories. You should read that. And what Kent says, even Kent writes in his lesser writing that while making totality, try to avoid rubrics with few remedies. Take general rubrics with more number of remedies. He says, he has given sub-rubrics. You can see in Kent repertory, there are general rubric in a chapter, and then sub-rubrics are there where 1 remedy, 2 remedy, 3 remedies are there. He says, no, don't take those. Or even if you want to take, you have to be very careful. The remedy has to really match. He says, take general rubrics. There's one example of constipation and stool. He gives an example. There's another example, I think, of paralysis or some numbness of the hands, tingling in numbness of the hand. The 2 cases he has given, and he explains how sub-rubrics sometime going very particular, you will get nothing, but you have to be generalized. So this generalized concept, we think it is Boger, Bonninghausen, and Kent did not follow. No, it is not like that. Kent also understood the importance of generalizing. He always understood the importance of generalizing, and he also generalized many of his symptoms. So, word of caution, what is it? If we are tilted too much to such towards such particular symptom with few remedies, then we should be very sure to match the remedy that is with the patient's symptom. I'm telling you again and again this because I want you to get this imprint. Like Glonine and Seneca comes, we have to go and read Seneca and Glonine in and out and see if it matches to the patient. Now here, of course, we are decoding a case. We have not seen a case, but practically when we are sitting in front of the patient, this is how I do it. If I get hooked on to one symptom, I feel this is very important. I will look the remedy and try to match the remedy. If I don't see similarity, I will forget the rubric and go to another. Now, in this case, Thuja was given. Okay, let us try to understand why Thuja was prescribed in this case. So the rubrics that was taken here was understanding was generalities left side. Number one, eyelids what? And if you see, there are only when you repertorize this, these are so what he did is that I don't know what he did, but I am thinking from my side. If you take only these two things, generalities left side and lids what's, I remember these subtle observations can help you so much you can't believe. I'll share you one case. I just shared a case. I just remembered. I'm handling a case of twitching. I got a lady. She has twitching here. Here right side, this part near the lips, just above it, and it happens. Twitching, continuous twitching happens. I might share this case sometime. So first time when she came, I took the case. Everything I did, nothing happened. Then again gave the remedy, nothing. 2 follow-ups, nothing, no recovery. In third follow-up, what I did is that I took the side, which side is affected. And in the past, she had conjunctivitis, lot of eye problem. And now I saw that because what on the upper lid? On the lids, upper or lower, I don't remember now. So when I repertorized only those 2 rubrics, I came to causticum. And then when I read causticum, I understood twitching of single parts. All those things started coming up. It really matched. I gave causticum and she got completely better. So making big totalities, we can form totalities, but totality can be misleading also. So we have to keep in our mind the most prominent symptoms has to be there. And whatever totality you make, if remedy is not matching, you have to discard it. What about the other probable symptoms? Urination nightly. There is urination. Now you can repertorize this. But you know what? There is urination problem. Means urinary organ is affected. Organ affection can also diagnose miasm. If you read psychosis, SORA, and syphilis, they all have got specific organ affinities, like remedies have. So when you talk about psychosis, urogenital organs. Whenever urogenital organ, urinary organ, or genitals are affected, predominantly it is psychotic remedy, psychosis. So he generalized. Now repertory role is gone. Now understanding of the remedy is there. So miasm in the background. This is miasmatic prescription actually he did. So he saw, he must have seen these 2 things, left-sided affection, what on the lid, and then miasmatic thing. So when totality does not match now, you should look for the anti-miasmatic remedies. That's what this case taught me. Thick neck. Now thick neck. Now this was something new for me. But when I read in literature, I'll show you, thick neck is also one of the physiological features of psychosis. I'll show you where it is written. Prescription was made on the basis of disposition. These are dispositional symptoms, anti-miasmatic. Not what happened, but to whom it has happened. So the beautiful thing is, in this case, the prescription was on not what happened. Okay. vertigo happened. No, to whom it happened? It happened to a psychotic patient. So it is psychosis. So when miasm is predominant, miasmatic things are predominant, and we keep giving, remedy based on totalities. That is why results do not come. The real culprit is always miasm, the fundamental cause many a times. So we as a homeopath, what I learned from this case is we have to develop our perception, our eyesight, our mind sight to catch these anti-miasmatic expressions. These miasmatic expressions, syphilitic, sora, psychosis, tuberculinum, maybe carcinosin. We should learn, these pointers towards these miasmatic prescriptions. Miasmatic taint was targeted here. As other local symptoms depict common symptoms of disease, apoplexy. That's what I thought. Maybe because he thought it could be apoplectic symptom. So he might have not taken into consideration about vertigo and all other things because that could be common to the disease itself. So how many times it happens that so much particularly we go and we take some very common symptoms of the disease itself. Now let's learn about psychotic little bit. Allen's encyclopedia. Now this thick neck. Now this, of course, I had read somewhere, but I wanted to find out where it is written because the posture. So constitution also looked like that. The constitution, the physical makeup also defines the miasm. So when you go in Allen's encyclopedia, neck and back, you open the chapter of neck and there it is written swelling of veins in the neck, extending down from ears with pressure. So swelling of neck. The thickness of the neck increases. Nodular glandular swellings become very hard. Again, you find thickness of the neck. Neck appears swelled so that the loose neck cloth is troublesome. So now you see the neck, how important this part is. It swells up. The neck cloth feels very tough. It is not like SS, tight clothing aggravates. The neck is swollen. Neck is becoming bigger. The cervical vessels are distended and blue. The skin of the nape of the neck is fatty. This side, nape of the neck, fatty. So you can see the fatty disposition around the neck. Neck becomes short and thick. Not short, basically thick. There's a book called Gibson Studies. When you go in that, it's a wonderful book which describes, like we have Gunamante, from where you can get features of these miasmatic features. Gibson is also one of the book from where you can get physiological and pathological or pharmacological impressions of these miasmatic remedies. Gibson says this drug, like Thuja, has strong affinity with epithelial tissues. Its irritant action leading to over-secretion by glandular cells. Hence, and hyperplasia of epithelium with formation of body or condylomatous growths. He says epithelium is affected, secretions happen, and that is why you will get warts and condylomata, and of course, fatty depositions. Affinity with mucous lining of urinary tract causes acute inflammation accompanied by yellow discharge. Now you can see. Henman said the same thing. When you read chronic disease, he says urogenital organ. So urinary organ, it affects the mucous lining of the urinary tract. So when he's talking about Thuja, actually he's talking about psychosis also. It causes contraction of uterine muscles. So urogenital organ. So what is the learning here? When we try to go deep in particular symptom, we may get lost sometime, misdirected, or prescribe superficial remedy. This was my learning. Now, I have also got some cases where I have prescribed on particular symptoms also. So it is a very risky business. Now, here requires a skill. If you just depend on the rubric and you get excited by that and prescribe it, your remedy will not act. So my prescriptions, I have got some cases where I have prescribed on very small rubrics, like taking from Boger, Clark, very specific Nair. The remedies have worked only when the remedies in those rubrics, maybe 2 or 3 or 1, it has matched the patient's symptoms. So reading remedy more and more, understanding remedy from its toxicological data, general symptoms, the modalities, the real symptoms. And matching at that level, if we can do, then only rely on these smaller rubrics. So this is very important. Okay. The idea of matching everything means all symptoms of the case with a remedy is erroneous. Now, this is an erroneous idea, I feel. Sometimes I feel a lot of our teachers and colleagues, they say everything has to be matched. Everything has to be matched from top to bottom. Everything, whatever patient says, has to be matched. No, dear. Not everything has to be matched. You go and read the second video of Boger, which I have introduced. Preface what he talks. Read the first video. What he talks about the mind symptoms. So many things patient is giving you, they are not real symptoms. Many of them are just created from their imagination. Many of them are just artificial, superficial symptoms. So it is an art to know the right symptoms. So get this phobia, get this idea that everything, whatever I hear from the patient has to match in my repertory. If you do that, you will always slog and struggle. But if you think my remedy has to match, then you will always be on the top. The most important symptom we should base our prescription, the most important symptom whichever is there, we should base our prescription on that. Okay. Diathesis. Don't forget to remember diathesis. Many a times in our cases, we are forgetting diathesis. The soil on which symptom develops has to be taken into consideration. So, learning miasmatic indications, we have to spend little time learning those miasmatic indications. Hence, a diligent homeopath should develop this skill of identifying miasmatic constitutional symptoms. Miasmatic constitutional symptoms. This is something interesting, right? Miasmatic constitutional symptoms. Through how? Physical signs, body makeups, organ effects, maybe mentals or generals. Like you read a remedy, na? Hence, you should read miasmatic constitutional symptoms. Every miasmatically predominant remedy like siphilinum, mercury, thuja, medurinum, maybe natrum sulf, sorinum, sulfur, they have got some general features which are not the remedy features only, but it is a feature of miasmatic. And especially these things like physical signs, body makeup, organs affected, you get a subtle hint of these predominant miasms. Physiognomy. Physiognomy from Gibson studies. Let us see what he says. He's talking about thuja, okay? Heavy trunk, short neck, thick, thin limbs, waxy, greasy skin, and irregular teeth are listed as a characteristic of thuja subject in a general sickly look. You see heavy trunk, thick trunk, short neck, thin limbs. So he's describing you the features, the physical body makeup. If you see these things, forget whatever patient is saying. You first address this because even the body constitution, the physical constitution, also is a part of your miasmatic traits many a times. The face is apt to be red with prominent network of dilated capillaries, especially alanezi. The hair is dry, often black, with tendency to split with the tips. Dandruff is likely to be present. The nasolabial folds are well marked. The lips livid with white transverse line across the lower lip, which looks like as if the subject has been taken, drink. Like when you drink milk from a glass, what happens here on the lips? White, white, white comes. He says nasolabial folds are well marked. It is vivid, white transverse line. I have not seen yet, but it is quite interesting, If now I know it, anytime patient comes and I see, maybe I can think that there is psychotic disposition. Pulsation of temporal arteries may be very obvious. This is very common, I've seen so many patients talking about, I get pulsations here in the temporals. Excessive hairiness may be present in women with growth of moustache, dark hair on the lips. So unusual hair. There is a rubric, unusual hair, hairy growth. So female coming in with high testosterone maybe, moustache comes, dark hair comes on the limbs. So that is also psychosis. Obesity may be excessive. Movements tend to unnaturally active and hurried. So patient might be obese, but movement tend to be unnaturally active and hurried. He's very active, very hurried. You've seen some people who are quite obese. but they're not dull and lethargic. They are very active, running and here and there. That doesn't match, right, with obesity. This type of obesity can be a part of psychosis. Hands are cold and clammy to touch. We think of silica, digitalis, but these, even silica, when we think, silica is also psychotic. So hands clammy and cold. So these are so good indications. Suppose you get a case, and you are struggling with the case and nothing you are getting characteristic. And you touch and patient says, my hand always remains cold and clammy. Maybe you can start with Thuja. Maybe dispositional symptom it is. Speech is either hesitant or hurried. Discharges are copious, foul smelling, often greenish and thin. Peculiar orders may suggest fish brine, garlic, or honey. so, so there comes psychology. We did physiology. There comes psychology. I'm not going to read now. Gibson studies. Sorry, that is a book you go and read. So he also talks about the psychological aspect of Thuja. Hence, the other miasmatic remedies also we can study. So this was a short lecture just to give you a understanding. And this was a quite interesting case for me because as we started Boger, we are talking about the 5 points. We are talking about the modality is so important, concomitant so important, other things are so important, totality is so important. But in between, I just try to show you a case where maybe the physical things or maybe the prominent symptom which you see right now, maybe we have to develop a vision, eyesight where we can see beyond things. What we are seeing, we have to see things beyond that. And that is those miasmatic traits. We have to learn the skill of identifying those things. So nice talking to all of you. Signing off here, Dr. Manish Yadav. Have a nice day, great learning, and let's take homeopathy to a next level. Thank you very much.